My name is Joel Williams. I practice in Chicago. My practice is centered on hip pathology, including injuries or fractures, preservation, and replacement. I'm joined tonight, hopefully, by Dr. Bob LeBeau. Bob is a extremely experienced and skilled physical therapist, and we're going to get some input from him about some of the rehab-specific questions. Bob, thanks for joining. I was just introducing you. You are my guru for all things physical therapy related to the hip, and this is the third session, sort of live session we've had like this, and I wanted tonight to spend a little bit of time focusing on, therapy. It's a key part of hip surgery. It's a key part of taking care of patients with injuries, replacements, preservation. It's a key part of when I meet somebody that has some sort of hip pathology and they're not an ideal surgical candidate or their symptoms are early on. Therapy often reconciles or improves people's hips dramatically. And you've seen patients that have been through all sorts of things, including after fractures, after replacement, after a hip scope, after a PAO, after a combined procedure, femoral osteotomies, etc. And I guess the first one is a great one for you. It dovetails into one of the lingering questions that I had from last session. And for somebody with like mild hip dysplasia that also perhaps has some element of impingement, what are the similarities and differences that you see on your end after they've been through a scope versus a PAO? Like, is this night and day? Are they similar? Or how do you think about that?
That's a good question. I mean, if you're looking at a mild dysplastic who goes through a PAO versus a labral repair osteochondroplasty, they do set up fairly similar. Waiting time for weight bearing, similar precautions. You want to be careful with the hip flexors, post-operative management, the scar tissue management. So they very much stay the same, except PAO is maybe a little bit longer, especially on the more simple procedures. I mean, that's not a simple procedure, don't make me say that, but just the ones that aren't, having pain for 4 years and they're centrally sensitized and their nervous system doesn't know which way is up and the pelvic floor is shot and the core doesn't work. Those guys are a different beat. But the ones who are pretty, like the borderline, I would probably say that how long they've been dealing with it, how often, if it's a more acute thing, talking about more like a year or less, they seem to do better, more like a regular old hip scope. That's the way I'd answer it.
Yeah, I think that is completely congruent with what I've seen in my practice, meaning there's data to support that, which is if somebody has an operation, a scope or a PAO or both, and they have a limp before surgery or they have muscle weakness, which coincides with what you just said, they've been dealing with this for a long time, and they're decompensating, then their recovering in that situation is definitely possible. It just takes a lot longer than somebody who comes in to get treatment right away.
Yeah,
The flip side to that is like, should we be more aggressive in recommending surgery right away for everybody that comes in the door? No, of course not. I think there's a huge percentage of people that get better with the right therapist pairing. So it's a sticky balance between waiting long enough to be sure that we've exhausted non-surgical things, and then also jumping on board, jumping into surgery, and then having the appropriate recovery afterwards to help before weakness and limps really become a major issue.
Yeah, that's a great question, because I see patients who've had it for a long time and they're like, should I have done this earlier? And it's like, well, the trouble is you probably have borderline dysplasia on the other side, and that may last you till you're 65 or till the end of life. Who knows? We don't definitively know. And I know there was a time that surgeons were doing some prophylactic surgeries, and it sounded interesting, but it's just too complex a surgery, especially the PAO. But I would probably say it should be a more common surgery because of the sequelae of it beats up the labrum, especially the borderlines that are a little less obvious. Beats up the labrum, then they have this labral problem, and then the labral, the hip arthroscopist says, oh, we could do this, but you have this shallow socket. But back to your point, these are the patients you have to go really hard, rehab, get the rotators working, get the glutes working, get the core firing, dissociation, and teach them that maybe it's not a good idea to do hardcore yoga and bend like crazy, and give some time. So it's a good thought.
Yeah, one of the questions that's come up, and it's actually lingering from the last live session, is what exactly is borderline hip dysplasia? And that's tied to question number 2 and 3, which is how's it different than regular dysplasia? And number 3 is how do you diagnose it? So I think I can probably answer all 3 of those with a couple of statements. One is this dates back to the original description of dysplasia, and identifying it as a very strong risk factor for having arthritis. This is from a paper in the 1930s from Germany from a guy named Weiberg. He's the person that sort of observed that certain hip sockets predisposed to having arthritis, and your propensity or your risk of arthritis is tied to your category of dysplasia. So severe severe dysplastics are at severe risk for getting arthritis, moderate dysplastics, moderate risk, and mild dysplastics, mild risk. And he also went on in that paper to say, mild should be substratified into borderline and mild. And maybe there should have been 4 categories up front, but that original thing has been misconstrued and misquoted and has become this nebulous term. And it originally started, to be precise, the original description is 20 to 25. Lateral center edge angle, 20 to 25 means borderline. 25 to 15 comprises the rest of mild, but really borderline is a subset of mild. And then moderate and severe are sometimes referred to as frank dysplasia or, moderate or severe dysplasia. And the gold standard treatment for years and years has been the PAO. I mean, that's a procedure that's been around since the mid-'80s and across the world, aside from some parts of Asia where they do a variant of the PAO called a rotational acetabular osteotomy. The PAO is the work. Arthroscopy is a relatively new kid on the block, meaning it's been around for 20-ish years, which in orthopedic history is a small chunk of time. And arthroscopy is wonderful for many conditions. And the thing that we're trying to figure out is, can we improve the results of PAO surgery by adding work inside the joint? And can we do that work arthroscopically? So a key question is, do I think, or does the clinician think, the symptoms are primarily from instability or dysplasia or from impingement? And the results of borderline hip dysplasia there are plenty of publications that support PAO, and there are some publications that report mixed results with arthroscopy. And I think there's a lot of patients that fall into that borderline group, and the specific. So is that person a hypermobile or very flexible person, which usually correlates, but not one-to-one with male versus female? And how big is their impingement lesion? So impingement in this context usually means they have a bump on their femur. So a male that's super stiff with a big bump is a different clinical scenario than a hypermobile female with a small bump. Technically, they're both borderline dysplastics with impingement, but I think the literature, it's incumbent on us in the literature to tease out those different clinical entities. And I'm going to flip it back to you. If you see somebody that's diagnosed with a labral tear, because the common denominator in all these scenarios is there's a labral tear or concern for it. When somebody gets referred for impingement or dysplasia, what are you doing hands-on from a diagnostic perspective to help figure out whether you should treat them as an impingement type person or an instability type person?
Yeah, I mean, you're 2 different type of patients. You're saying one's a little more stiff. They're the capsule, and it's something that a good hands-on therapist would do. But how is their capsule moving? You get it to the end range, internal rotation, like some variation, hip extension, abduction, all those motions, and you just pull on. We call it jiggling the joint. The research isn't great on what does what, or it's hard to really tell what it's really doing. But if it feels like it's not moving, and back in the olden days when shirts were made of cotton, they didn't flex very well. So that's what you're seeing. You're seeing a stiffness or a rigidity in there, and the impingement is because the capsule's not gliding and rolling. Similar to the shoulders, it has a long history. But the instability ones, they're a little bit more mobile. They don't seem to have that capsular pattern. They have more frank weakness, especially with your rotators. Their glutes aren't working very well. And I use handheld dynamometry or some type of a strain gauge to really get a quantifiable number. I'm not just doing hands-on testing. So I just want to see it. They more than 10% different weakness, right to left rotation. And then also looking at hip trigger points. Are they tender to palpation? And I'll look at the whole deep rotators, look at the psoas, look at the adductors. Are they hot? Although both groups have muscle trigger point issues. I would say that the more dysplastics, the micro instability, they have pain when you're pushing them a little bit beyond that range, rather than the simple impingement or the straightforward impingements are more, you get them to the end of range and they jam. If you take them back and twist them a little bit, they're not hurting, but the instability ones will feel, but it won't feel as stiff. There's definitely clinical relevance, although I don't have access to imaging. Well, I do, but I can't order images. So it's interesting to correlate the clinical picture with the other one. But generally, the one's a little weaker, one's a little stiffer.
Yeah, I completely agree with that. I wish it were as simple as saying it's the diagnostic part that I think is challenging for everybody. Imaging is a part of it. So the thing that makes us put on our detective hat, start thinking about it, is pain in a certain part of the body, the symptoms, like how the pain's being manifest and showing up, the exam, just as you said, the imaging. And you got to put all those things together and go over the treatment options. And sometimes that's the right physical therapist pairing. Sometimes that's a scope. Sometimes that's an osteotomy. It all depends on the details. So borderline is super confusing. And we're not done talking about it and thinking about it. So for right now, we take these on a case-by-case basis. I think in time, we're going to be able to figure out who's a good fit for scope, who's a good fit for an osteotomy or structural correction.
It's amazing that just 5 degrees, I mean, we think 5 degrees is a lot. It really isn't. Very close to the standard error of measurement. I don't know what it is on imaging, but when we measure people, 5 degrees, you just shrug your shoulder. 15
Absolutely.
Degrees is different, but you're talking about, if you're building a building that's 5 degrees off, it's going to be a problem. But humans, we live with compensations through our lifetime. and get more compensated as we grow older. And then compensations go into different spots. Like you're talking about, is it just the hip or what's spine doing? What's the pelvis,
SI
the
joint.
pelvic floor? The SI joint. That's another whole basic live discussion.
Yeah, just today, I just finished seeing patients in the office. And to the viewers, thank you for your patience in delaying this 30 minutes. And Bob, thanks again for delaying this 30 minutes. But I just finished seeing somebody who has pain in their groin, pain that's responded to a diagnostic injection inside their hip and a second pain location right over their SI joint. And I see that a lot. And there are many times where I think there are two different entities occurring, but the reality is the hip's moving and functioning abnormally, and that stress and that abnormal movement gets sent somewhere else oftentimes, and the symptoms show up as SI joint. And I've had patients just like that undergo whatever sort of treatment for their hip, and both pain locations improve. And in other contexts, I've had patients with a hip problem that improved after an operation, and their SI problems persist. So it depends on how deep into this into the compensation rabbit hole you want to go, but it's a real thing.
Yeah, and sacroiliacs are tricky. They're very obvious, and in postpartum women, they're just laxity. But your ones that are stiff, we call a last cluster, where we challenge it in multiple different directions and angles. But back to History down in St. Louis, you did a great paper in 2009. It's been a long time. Where's the hip hurt? And it could hip hurt easily in 7 to 9 places. Mm-hmm. So, I mean, it could hurt other places. So if you're looking at the Fortin sign, I have pain here. It's like, that could be coming from 5 or 6 places easily enough. And then the concurrent ones are the challenge. The ones who've had the SI joint and they have a hip labral issue or a dysplastic, it's a compensation. And you guys clean this beautiful hip up and they're still having SI problems. That's something for our team to pan out with you guys.
All right, some other ones I'm drawing from the list. The one that's come in so far is from Laura Potter. And the question is, how do most people do with screw removal? Usually that is an outpatient procedure. We open a portion of the healed incision. Screws come out, occasionally one new incision, so I don't have to extend the existing one into a longer direction. People go home the same day. I do recommend crutches just till people's balance has come back and they're not limping. And then usually it's helpful in that context to reboot the physical therapy. So if somebody's healed after a PAO and they have no symptoms at all, then usually I'm not talking about screw removal. But usually a screw removal is accompanied by some lingering symptoms. And once the wounds are healed, I think revamping the physical therapy again can be very helpful. If there are other questions from viewers that are watching this live, feel free to send them in. Otherwise, we do look at the questions that have come in through social media. Otherwise, the list I'm looking at is 15 questions long. So I don't think we'll get through every single one, but I'll try to tie together some of them. What role does physical therapy play after a PAO? I think it's crucial. I broadly speaking break it up into several different phases. The first 6 weeks, I'm really trying to baby the osteotomy. In other words, 30 to 50 pounds of the operative side. And then that's when I get the x-ray that determines whether we're moving on to phase 2 or need a little bit longer in phase 1. Vast majority of people at 6 weeks get an x-ray and we move on to phase 2. And that's really where Bob becomes crucial. I think for phase 1, your hands are tied a little bit. It's just range of motion and everybody wants to start strengthening and getting off the crutches and oftentimes feel ready for it. But just to give it a chance to heal properly, I wait 6 weeks. Phase 2 is variable. Some people get off the crutches in as little as a week or 2. Some people need more like 2 months. And I rely on Bob and skilled therapists to make that determination and make that progression to go from a walker or 2 crutches down to 1 crutch, sometimes a cane, and keep people from limping and keep their pelvic girdle. And then after that, most people at some point during phase 2 call the office and say, I feel great. I want to go back to dance or football or soccer or whatever. My general advice is to hold off until 6 months. And, Bob, I want your input on that. Am I being too conservative with that 3-phase sort of progression? Should I be more aggressive? Should I be more conservative?
You like to work on criterias. Do they have the strength, like in the ACL literature? Are they 80%? Are they 90% strength? If we look at strength, that will give us some numbers that will help you out. I don't think it's terrible holding back a little bit, 6 months. I personally see a lot of patients who bailed elsewhere. So by the time they see me, it's about 6 months anyway. But I think being a little bit more patient, especially the hip flexor, the iliopsoas get really irritated in both labor repairs and PAOs. The gluteus medius, they can stabilize their pelvis, their pelvic floor. That all takes a little bit of time. So before going back to football and dancing, we have some time. You think preservation is preserve it so that you can get 75 or 65 or 70 or maybe the end of life without needing a replacement. I mean, replacements are fantastic, but you don't want one when you're 50 or earlier than that, actually. So I like to tell my patients, let's be a little more patient, but I also like to look at criteria, look at strength, what we call limb symmetry Plyometry Index, tons of literature on the ACLs, but in the hips, we're kind of laggard with that. But is it 75% side to side? Is it 85%? Is it 90? I mean, if they're 90% side to side strength, I'd like to push them and move them forward, and then look at quality of movement. Are they wobbling? Are their pelvis stable? Are their muscles acting the way they should? Are their core firing before the big muscles? Their small muscles firing before bigger muscles? So that's all the criteria before we move them along. I think that being said, probably goes along with your slightly more conservative program. And I'm fine with it, actually.
I've messed around and tried to shorten it a little bit in some of those phases. And on the whole, I'm not like, I think this is in line with the national norms. I don't think I'm doing anything that's too out there. But every time that I try to shorten or think about shortening it, I've got somebody that overdoes it and we got to dial things back. And it just really makes the recovery last longer than it needs to. When you try to push it, it flares up, you calm down. Push it, and then all of a sudden, instead of starting your sport at 6 months, we're really getting ramped up at 8 months or something later on.
Mm-hmm. And the body's healed and it can take it. The nervous system is given a chance to reconnect. Mm-hmm. Sometimes we say it takes 6 months for the nerves to calm down, a year for them to settle down even more, and 18 months for them to get back to normal. And I used to dance around this as a younger therapist, but the more gray I have in my hair, the more I say in first day, 6 months, 12 months, 18 months. It takes time. Yes. Unfortunately, but you have your 14-year-old kids getting their not PAOs, but labor repairs, and it's all right, we got to give it some time, or else you'll be miserable in your 20s and 30s, dealing with this thing.
Yeah.
So give it a little more patience.
All right, this next one is for you. What mistakes slow recovery down the most?
Just lifting that hip up and down, we have to be very cautious. Man, you can't see me, but if you're putting your clothes on, lifting it up, I think that's one of the bigger ones. Weight bearing too early. You had mentioned walking with a limp. I want to get out of here. I don't want to use crutches. I'm too proud. I think overdoing it. And then pushing range of motion too fast, especially the PAOs. Pushing range of motion rather than just letting it go. And then I'm going to just backdoor the pelvic floor and the lumbar spine. To be a good hip therapist, you have to be a good lumbar therapist first, or a second, or whatever. But the L spine, the management of that is really important. And then probably further down the road as things heal, capsular management. So if a physical therapist doesn't do good capsular management, like the circumductions and the joint mobility, after it's healed, they tend to stiffen up a little bit more and be more problematic. But back to patients, probably too much active leg raise, too much weight bearing too early, and just overdoing it. You have to appreciate that we're not running 10Ks at 6 months after these things. It takes a little bit longer. So overshooting definitely activity. Just be patient with it.
All right, another one that's perfect for Bob. I have my opinion. I'm going to tell you in a moment, but I want to hear yours first. Can physical therapy alone ever treat borderline dysplasia successfully?
The answer is it's worth a try. People have borderline dysplasia before they have a flare-up that brings you into the medical community. So it's a great idea to try to calm it down. If there's a joint mobility technique or something for pain management, getting the hip rotators stronger, getting the glutes stronger. And then a lot of motor control, like core activity, dissociation. A lot of times the core is overused or underused, the core muscles, the transverse abdominis, multifidus, pelvic floor, are weak and inhibited. So the hip flexors and the hip adductors are trying to stabilize the pelvis, and then it just throws the hip out. So anyways, back to that, a lot of motor control, a lot of activity modification, a lot of calming the thing down, and then see if you just go back to a dysplastic hip, borderline dysplastic hip. But there's the fine line. I would hope within 6 weeks that thing is quieting down and you're getting back onto it. I wouldn't spend too much of your therapy dollars if it's going down a bad path. I'd rather save that after surgery.
How much time would you say it takes for you to get a read on that?
I think I just said 6 weeks of therapy is pretty good. Although I had someone not long ago that I'm like 3 sessions in, and I'm like, I think so. I think the better I get, the probably more willing I am to make a prognosis one way or the other. Yeah. But I'm still working on that. I'd love to have some criteria and say, give me 4 or 5 visits or something, and then go from there. So settle with 6 visits. Then you go back and it's a team effort too. If they're starting to make some progress, they'll say, let's keep you out of the cold, keep you off the grill, or time to go on.
So Cassie, just chimed in. It's so hard being patient, but I've definitely been in the setback camp from pushing too quickly, too fast. My physical therapist learned a ton from my first PAO recovery. And that's very insightful perspective, having been through one already and knowing what it feels like before and after you're recovered, I think is what many people deal with when they have bilateral dysplasia. And the second side tends to go a little bit faster, not for everybody, but just people know what to anticipate. And a huge part of this is not knowing the unknown and knowing how hard they can push and when they can push, because it's a balance. If you push too hard too quickly, you're going to have setbacks. And if you don't push hard enough, your recovery is just going to take a lot longer. And for a lot of young active people want to get back as quickly as possible. And they have, jobs and families and exercise that they want to do, but it's a balance for sure. So Cassie, good job being patient. So next up, there are some generic questions. Actually, before I get into this, Bob, you and I were texting or chatting a little bit more about the exam maneuvers. And we just talked about how it's not just as simple as the history, not the exam. You got to put all those two together with the imaging. Do you think if you were blinded from the imaging, just based on your exam, you can, if somebody refers you impingement, borderline, you can make an assessment? Is that enough, just your exam, to say, I think you're behaving more like this or like this, based on the capsular mobility and other things you mentioned?
Not having imaging, actually I do have access to the imaging working in MR, but not having that in my corner is an important thing. And in graduate school, I took a class on imaging, so I kind of know it, but I definitely am blinded to it. So I have to go by my feeling and gut of what does it feel like, what's happening there. I could probably be a good job triage it and saying, I think this is moving a little too much. I think the problem is more that instability. So I would say I probably can. That would be an interesting study, though. What do you think? Let's image them.
Yeah.
And see who gets the prize at the end of the day. That'd be a pretty cool study.
All right. So the next are some questions that come up a lot, and feel free to chime in. First one is, what does hip preservation actually mean? And that is sort of an umbrella term. It encompasses things like hip arthroscopy. It covers things like a PAO, or its counterpart on the other side of the joint, which is a femoral osteotomy. It encompasses treatments for people that have conditions like AVN or avascular necrosis. There are sometimes bone grafting or other operations like a core decompression. It's really anything that's done on the hip that's not a replacement, and it's not to repair fracture or an injury, I think is a safe way to think about it.
Yeah, it's a big umbrella.
A lot of times it becomes synonymous with a PAO or a hip scope or something like that. But the reality is it's an umbrella term, and it's broad, and it sounds vague, but it's actually precise, because it excludes all the traumatic things. It excludes all the replacement things. And in the middle is this field that I find very fascinating in helping primarily people without arthritis that are younger stay active.
I'm an older therapist, been doing this for 32 years. And back in the day, you had bursitis, a fracture, or arthritis. That was your three. And that was in the late 90s. And then I think Bush Joseph did the first one I ever heard of. It was probably in 2005 or something like that. Like, what? What did they do? What do you have?
Yeah.
And that just started. And it has a lot to do with imaging, and we could image things a lot better. And you guys have studied it like crazy, and we're just trying to keep up.
Another one we sort of already touched on, but just to summarize, the question is, what's the difference between PAO and hip arthroscopy? PAO stands for periacetabular osteotomy, and that's an incision that is made to move. And so through that an open incision, the bone is being cut, the hip socket's being cut from the rest of the pelvis to be repositioned to a better spot to optimize the mechanics of the hip joint. The hip arthroscopy is a way to look inside the hip joint and, number one, confirm diagnoses that you think you've made on the MRI, and number two, treat things like a labral tear or impingement. It's relatively, just as Bob said, first patient he saw was just 20-ish years ago. Osteotomy surgery's been around much longer than that, and arthroscopy is here to stay, and there are many conditions which benefit from it, but a key part is seeing somebody that's well-versed in all sort of hip conditions so that you're getting an honest appraisal as to whether you're a candidate for arthroscopy, you're a candidate for an osteotomy, or both, or what for the patients that have a controversial diagnosis or a couple different treatment options, hearing the pros and cons of each, I think, is a key part of it. Next one is, can PAO and arthroscopy be performed together? Short answer is yes. Long answer is sometimes we break them apart, sometimes we do them together. That's a very long-winded answer. It depends on a lot of details that sometimes we get into in the office, but I think we'd run out of time. But the short answer is yes, in some situations can be done together. You've seen enough. We talked about the difference between PAO and scope. You've seen enough patients that have had a scope and PAO, like a scope done, a week later a PAO. Does that fall into the same sort of recovery from your perspective as a scope alone or PAO alone?
I can't tell it that it makes it worse, having a second surgery. And you appreciate that you only have one more week of downtime of recovery, which is good. And I think, like I said, the PAO, a scope is not that long of a surgery. That you guys are doing it for about 45 minutes now or something like that. It's a really quick thing. I think it's probably a little less traumatic. I think it's probably an appropriate way of doing it. A little less aggressive on the body. Doing it twice rather than doing it once at one shot.
All right, Bob, how about this one? What are good progress markers for a PAO recovery? We touched on some of them, but just are there warning signs that make you think this person's headed for trouble or this is going to be a poster child?
Kind of the red flag or yellow flag, I guess. Pain with active flexion after probably 4 months. I'd be a little bit nervous with that. Inability to extend their leg, past probably 5-10 degrees, probably more optimal. But some patients who then extend into the spine and the SI joint. So if they have capsular deficits and they can't extend, that's a challenging for me. And then strength deficit. If it's 50% at 3 months, I am going to get a little nervous. I don't strength test till probably about 2 months. I think at about 8 weeks, I'll do a handheld dynamometer to see where their strength is, and then I'll just keep progressing well. I get nervous with that. Is there something else limiting them? SI joint pelvic floor is. I'm not a pelvic floor therapist, but seeing the work in action. Sometimes you guys know him. Send this lady off to a pelvic floor therapist for 3 or 4 visits or something. Just put that base back. So painful hip flexion, extension, strength deficits that are not progressing, and then just global capsule stiffness. That would be my 4 things.
This is a good one. I think I'll share my thoughts, and then I want to hear Bob's. The question is, how do outcomes compare between PAO and hip replacement in younger patients? That's a tough one. I think, so the classic example that we can debate, forever in a room full of hip experts is, let's say, a woman that's in her early 40s with, let's say, no arthritis on the x-ray, maybe just one cut on the MRI that makes it look like the cartilage is thin, the labrum's torn with mild dysplasia. If that person shows up in somebody's office that only does hip arthroscopy, they're probably going to be recommended for that. Same thing for osteotomy, same thing for replacement. But I think there's a role for all three. I think under the right lens, yes, I've done replacements in that context, I've done osteotomies in that context, and I've done labral repairs in that context. And it all depends on the details and what the goals are, I think, first and foremost. And there's pros and cons to each of these. I think the most happy patients that I've done replacements on have moderate to severe arthritis that are active, that want to get back to normal life, including sports and going for long walks and being active. When I start to do replacements, and this opinion is shared by other, hip surgeons, the results for young patients with very mild arthritis is variable. And it's not to say there's no role for it, but it's just hard for me to predict who's going to be a grand slam versus who's going to come back in frustrated because they're not progressing, because their grandma, their aunt, or their uncle, or their neighbor had a replacement and it was wonderful.
Yep.
And those are 2 different scenarios. On the other hand, when I do a PAO on somebody that's in their 40s and they have just a hint of arthritis, like if they have fulminant arthritis, there's no way we're talking about PAO. But I think there's a role if they have just a little, like on the MRI, just a little bit of cartilage thinning. Yeah, I think there's still a role to discuss PAO, but it's got to be a very delicate conversation with guarded expectations, because I don't think that's going to be a grand slam if we do a PAO. I think it's going to buy them some time, but the likelihood is at some point they're going to get a replacement, and it's, I think, incumbent on us as clinicians to predict how long that PAO or that preservation option is going to work for. Otherwise, I think if it's less than 10 years, somewhat arbitrarily, then no, we shouldn't be talking about preservation. It's such a long, you can see my answer is such a simple question, it's that long-winded. And that's somebody also that we're going to exhaust non-surgical treatment on.
Yeah.
And that's somebody that I rely on your input to tell me if they're improving with physical therapy and injections and all the non-invasive things.
There's something that I want to add to this, like how well do they recover? How good is their nutrition? How good is the rest of their body? What's their home life environment? Can you trust the patient? You get a feeling like, man, if I do this massive monster surgery and move all these bones around, can I trust them to do what they need to do and not do too much and do the right amount? Do they have the mentality to the challenge ahead of them? Are they mentally tough enough to do that? They used to do bilateral knee replacements on patients, and the only one I ever saw that did well was a former Pakistani Marine guy, was probably used to being beat up by the Indian Army, and so he did the bilateral knee replacement phenomenal. But his psychosocial, he didn't mind. But your patients who have really low pain sensitivity or high anxiety, fear avoidance belief issues, those patients, you might, like I said, push to therapy and then wait until they go and do a hip replacement, because KOs are not easy to go. I'm 53 right now, and I used to think, man, you go into your 50s and you're having labor repairs, you're crazy, you just might as well wait. But there's still some people who do well in their 50s, but it's like you said, a delicate conversation, and you really have to, put them to the strainer and see who will do well. We probably have figured out who are the responders and who aren't, and that should be more of a scientific algorithm rather than I want it now, because it's not an easy thing to respond to.
That ties in really well to the next question, which is there an age where PAO becomes less effective? And there's plenty of good literature. I think I'm aware of a couple of publications that say results are guarded or compromised a little bit once you reach 40 or you're older than 40. But there are plenty of other papers that show good results. And I think the way I think about that is the mileage, not the year. That's where being really critical in looking at a high quality MRI becomes important. And if there are any signals or warning signs that this is just beginning of arthritis flaring up, then we avoid preservation in that context. I think the oldest patient that I've done a PAO on is, I've for sure done a handful in the mid 40s, but I think it's critical to be super selective in that group and be honest with expectation and describe the PAO or the preservation option, describe the replacement option, and oftentimes let patients make their own decision. I think that's a key part of it, which ties into the next one. Can younger patients get total hip arthroplasty? What's the youngest patient you've taken care of, Bob, after a replacement?
That would be an AVN in their early 30s, and then some dysplastic in their late 30s. So somewhere in the 30s, except I probably have seen an early 20, but that was like a car accident. Those guys, you just have to be honest. Your next one's going to be interesting, and your one after that's not going to be interesting. It's going to be really tough. But quality of life is important. I'd rather risk hard surgery in my 60s for my second revision and enjoy my life until then. That's honest.
That's a really great way to think about it. Most hip replacement's a phenomenal operation, and especially for people that have moderate to severe arthritis or they don't have a preservation option. Yeah, those are situations I think have done. The youngest is for sure in the 20s. Exact age, don't know off the top of my head, but it's usually in desperate times like that. And like you just said, the first one is usually the best one. And when it wears out, we have to revise it. That's when things can change. Revision surgery is not the same as primary surgery.
Second revision's even worse. Now I counsel my younger replacements, go easy on that thing.
Yeah.
You're not jumping off your roof onto that leg.
Yeah, that's a controversial one. Some surgeons, the spectrum of post-operative restrictions after replacement goes from do not do anything high impact ever, like running, jumping, skiing over here, to no restrictions at all and everything in between. And I think it's important as a clinician to educate patients as to what's going to make their hip replacement last a long time and avoid revision versus what are the risk factors that may make it wear out sooner. And that's still something that people are working on and teasing out. But for sure, I think it's similar to my comment before about it's the mileage, not the year. The more steps, more pounding you put on your replacement just stands to reason. It's a mechanical device, and that wear is going to be accelerated. It's a philosophical thing.
Right. Their patients are getting 20 years out of these things pretty routinely now. It's not like 10 like they used to do it, but 20, you can push 25.
All right. Well, I think that's all the questions that I had sort of in line based on the previous sessions. We addressed all the ones that came in. Anything else you want to add or comments, Bob?
There's PTs who do a lot of hips. This is not a simple thing, something that requires a little more patience. And there's patients who you could just ask the receptionist who's good with hips, who's good with challenging hips. And I consult with other therapists or I co-treat with other therapists a lot because I want other people to do well with this, because having the proper capsule management, muscle management, activity management, proper motor control exercise makes hip repairs better. And therapists have to appreciate and having a good team too. Make sure you have a good team with the physicians, being able to communicate with you guys. You guys have a great team, easy to communicate. If I have concerns, if you guys have concerns or challenges, you have to have someone who's good at being a team. This is definitely a team thing. Find people who are good at it, and then if your therapist isn't good at it, just tell them to find someone who's good in teaching, because I love teaching about this. So someday I won't be able to do this anymore because I'll be retired, but I want other people to do well, because this is something that it's important for people to have the right therapy at the right time, the right guidance. It's not regular old therapy.
I totally agree. And most people are going to therapy for their hip either have bursitis or arthritis or a fracture. And this is a whole different arena that requires somebody like you who's passionate about it and is taking the time to develop an expertise. I recommend Bob or somebody that Bob is trained, and if that's not feasible because of geographic constraints, then I usually text or email Bob and say, hey, who do you recommend in this part of the state of the country that would be a good direction for the patient to go in?
And again, therapists who are good at this are happy to. Outcomes just is more important than our pride or our busy schedule. So I'm happy to do a little mini weekend course and show my clinical pearls and just be part of a forward team.
Thank you so much for joining. Have a good evening.
Take care.